Welcome to today's Explainer, where we're going to explore a really fascinating and honestly kind of scary blind spot in medical statistics. Look, for anyone focused on truly understanding how we evaluate medical treatments, you already know that data drives absolutely everything. But what happens when the math we rely on actually hides the truth? Today, we're going to see why measuring the true clinical value of a medical treatment requires looking way, way beyond just the final destination. Okay, let's dive right into this by opening with a seemingly impossible statistical paradox. Just imagine a clinical trial evaluating a brand new chemotherapy agent for metastatic pancreatic cancer. As we analyze the data, we realize we have a situation where the drug works absolute wonders for the patients, but a standard statistical analysis concludes that it is a total, complete failure. So, how is that even possible? Well, let's put some real numbers to this. Imagine this advanced treatment successfully delays the progression of this deadly disease. The patients receiving the standard chemo live for an average of 2 years. But the patients in the treatment cohort receiving the new chemotherapy agent, they live for an average of 4 years. That's 2 extra years of life. And in the realm of advanced oncology, that is a massive, truly life-changing victory for those patients and their families. But here's where it gets crazy. Notice what happens when we reach the end of the 5-year study period. Despite the incredible difference in life expectancy along the way, both patient groups ultimately experience a 90% mortality rate exactly at the 60-month mark. So at year 5, the final tally of survival is literally identical. 10% of the treatment group and 10% of the control group are alive. This brings us to a fundamental concept: relative risk. Relative risk is a metric that evaluates the cumulative incidence of an outcome evaluated at one specific predetermined endpoint. It basically functions exactly like a destination snapshot. It looks at the total tally of events at one exact moment in time, and it completely ignores the timeline of when those individual events actually took place. So because both of our treatment groups hit 90% mortality at exactly 60 months, if we calculate the relative risk, the cumulative incidence in the exposed group divided by the incidence in the unexposed group, our calculation is exactly 1.0. And a relative risk of 1.0 implies there's absolutely zero difference between the two groups. A cumulative analysis at year 5 falsely implies the medication is entirely ineffective. And this brilliantly illustrates the failure of relative risk in this context. It perfectly maps the start and the finish line, but it completely misses the time-to-event dynamics. It fails to capture whether the patients in the treatment group lived significantly longer before passing away, or if they all suffered early mortality within the first few months of the trial. It is just completely blind to those incredibly valuable extra years of life. Which brings us to Section 1, the speedometer of the trial. Enter the hazard ratio. To fix this massive blind spot, investigators have to shift away from that static snapshot. We need a way to capture the continuous velocity and timing of clinical events across a continuous timeline. Enter the hazard ratio. Derived from advanced survival analysis techniques, the hazard ratio acts as our live telemetry. Instead of looking only at a final, static tally, the hazard ratio constantly monitors the rate at which events are occurring among the individuals who are still alive and actively participating in the trial at any given moment. Basically, it measures instantaneous risk. So, the crucial takeaway here is that if we run a survival analysis across the continuous timeline of our pancreatic cancer trial, it yields a hazard ratio significantly below 1.0. Unlike relative risk, the hazard ratio accurately demonstrates that the treatment group experienced a much lower risk of dying at any given point during the journey, proving the drug's massive life-extending benefit. Now, let's move on and see how this builds into another really critical, real-world problem in long-term clinical trials. What happens when you're tracking that journey and a patient suddenly just vanishes from your study before the finish line? Well, in biostatistics, this phenomenon is known as censoring. Censoring occurs when a patient drops out of a study early, maybe they're lost to follow-up because they moved away, or perhaps they pass away from an entirely unrelated cause, like a car accident, for example, before the trial is over. They didn't experience the clinical event we're actually studying, but we no longer have their data moving forward. And this is exactly where the choice of metric really matters. Relative risk clumsily treats these dropouts as missing data or statistical failures, which can severely compromise the analysis and lead to attrition bias. Survival analysis, however, cleanly accommodates censoring. It preserves the patient's valuable contribution up to the exact day they exited the trial, which maximizes our statistical efficiency without skewing the final results. Moving right along to section 2, visualizing the journey, the Kaplan-Meier curve. Now, grasping these mathematical concepts conceptually is great, but we can actually visualize these time-to-event dynamics. We do this using a specific type of graph called the Kaplan-Meier survival curve.
On a Kaplan-Meier graph, the line represents the probability of survival. Every single time you see a step down or a drop in the curve, it indicates an event, like mortality, has occurred. But look really closely at those little vertical tick marks along the lines. Those tick marks perfectly account for right censoring, marking exactly when a censored patient left the study without experiencing the primary event.
And running under the hood of these visual curves is a calculus-based technique known as the Cox proportional hazards model. This is the advanced statistical engine that actually calculates the exact instantaneous risk at every single moment of the trial, allowing researchers to adjust for various factors and generate those highly accurate hazard ratios we talked about earlier. So let's synthesize what we've learned today. The fundamental distinction when comparing two treatment groups over time is separating cumulative risk from time-to-event dynamics. Relative risk is your static final tally, it's the destination. But the hazard ratio is the continuous velocity, it's the journey. Mastering this distinction ensures that a researcher selects the hazard ratio whenever the continuous timing of an event is just as clinically meaningful as the final outcome itself. This is exactly why, on advanced examinations, a clinician must be able to predict how these metrics diverge when a treatment shifts the timing of a disease without altering the ultimate survival rate. I'm going to leave you with this final, kind of provocative thought. If we rely solely on static endpoints, our math will absolutely lie to us. How many highly effective, life-extending medical treatments might we have just abandoned in the past, simply because we measured the destination instead of the journey? In medical statistics, and honestly perhaps in life, looking only at the finish line can truly blind us to the miracles happening along the way. Thank you so much for joining me for this explainer. Keep learning, and always keep looking at the data from every possible angle.